For PanNETs, we wanted to tackle an issue that's fairly problematic. Is what is a malignant PanNET, or how do we define malignancy in a PanNET? Because this has been a controversial topic for forever, actually. And I wanted to provide you some perspectives from pathology and otherwise, and hopefully we'll have better appreciation of malignant nature of neuroendocrine neoplasia. So currently, WHO classifies or recognizes two very different groups. One is neuroendocrine tumor, which we still call well-differentiated neuroendocrine tumor, although we don't really need to specify the well-differentiated word, because tumor, by definition, refers to well-differentiated in the neuroendocrine neoplasia setting. And the other one is neuroendocrine carcinoma, which refers to those poorly differentiated malignancies with neuroendocrine differentiation. Again, we do not need to see the word poorly differentiated, but I like re-emphasizing when I'm rendering a diagnosis, I still put poorly differentiated just to emphasize we're dealing with this high-grade malignancy. Now, what I will try to tackle today is the well-differentiated ones, what we used to call islet cell tumors, because they really resemble islet cells. They try to be islets. They have the vascularity that islet cell. You know, remember, islets, they produce hormones and they secrete the hormones immediately there. They're endocrine. They don't secrete it to the duct, so they need the vessels. And they do that when they are neoplastic as well, so they are very highly capillarized neoplasms. Again, we used to call them islet cell tumor or islet cell carcinoma. At some point, we used to call them pancreatic endocrine neoplasia. Now we call them neuroendocrine to distinguish those from adrenal gland and thyroid gland, which are the true endocrine organs. One thing you have to remember, though, if you're reviewing the literature on PanNETs, you have to enter the word endocrine as a combination. It's actually, this happened to me. I was looking for one of our papers. I go to the literature and I cannot find it. I said, what happened? Did they delete this paper? Then I realized we had written this before the change to neuroendocrine. It was called endocrine neoplasm. So it's important to, when you're doing a analysis of the literature, recognize that they were reported under different names previously. So well-differentiated neuroendocrine tumors are essentially neoplastic versions of islets of Langerhans, as we mentioned. So they form the nest, what we call trabeculae, festoons. There are different descriptive terms we use, but this architecture often and almost always present, and it's the way we recognize these tumors and distinguish them from other neoplasia. Again, capillarization or this delicate vascular network is also an important feature. When we come to poorly differentiated neuroendocrine carcinomas, they are very high-grade malignancies. They're essentially small cell cancers of, as they are described in the lung, very rapidly progressive, very malignant, very aggressive neoplasms. In essence, we think of them as cancers of immature cells. I kind of view them as stem cell cancers because they can have different differentiation lineages too at times. And for us pathologists, it is poorly differentiated means it's hard to recognize, meaning it's not doing something normal. So we often have the differential diagnosis with these tumors of melanomas, lymphomas, and all kinds of high-grade malignancies that do not show their face to us are in the differential. And as such, they are very proliferative tumors as well. Ki67, by definition, is about 50-60%, and invariably it's about 80%. If you have a Ki67 lower than that, you should be wondering if you're overdiagnosing something. Now, let's go back again to well-differentiated neuroendocrine tumors, or what we mean by PanNETs, pancreatic neuroendocrine tumors. Now, these are low-grade malignancies, and I cannot overemphasize this concept. They are all low-grade malignancies. It is a spectrum. It's a spectrum in the sense that if we catch them very early, very low proliferative, yes, of course, they behave benign if we resect them. The behavior is perhaps similar to GIST. GIST are like that too. We see GIST now, morbid obesity operation. There's a small, stomach tumor on the wall, 1 centimeter, 0.5 centimeters. Nobody pays attention to them. Yes, we catch neuroendocrine tumors extremely small. They are more benevolent. But on the other end of the spectrum, especially when they have Ki67 going over 10, they're infiltrative, They are true malignancies that can be aggressive. Now, this is important to recognize. 10-year survival of all comers of neuroendocrine tumors is 50-60%. Okay? When you compare this with all comers of breast cancer, it's 85%. Prostate cancer, it's 95%. So we are dealing with a malignancy that's actually more aggressive than breast and prostate. So it's important to remember. A lot of the prostate, most men are going to get prostate cancer if they live long enough, right? Over the age of 100 in autopsy series, 100%. Over the age of 70, it's about 60% prostate cancer. Most of them are indolent, just sitting there. They're not going to do anything. Yes. Neuroendocrine tumors are not quite like that. 10-year survival is 50-60%. I'll show you more data on that. Now, there's one exception that needs to be kept in mind, which actually a very puzzling situation in terms of management are those neuroendocrine tumors that arise in the context of syndromes like MEN syndrome, VHL syndrome, Mahvash, like glucagonomatosis, insulinomatosis cases, in which the term dysplasia is not used, but probably we should use them. You see in this pancreas numerous tiny little islet proliferations when they're resected. So they are not normal. I mean, I look at this islet, it's large. Can I have said that this is really abnormal? Maybe, maybe not. But then you see a spectrum, larger ones, and eventually some of these become more clonal appearing, unihormonal, and have a capsule and form a well-differentiated, true well-differentiated neuroendocrine tumor. This is similar to those of you who if you are doing gastric cancer work, we see neuroendocrine proliferations called enterochromaffin-like proliferations in the stomach due to atrophic gastritis, and same kind of proliferation moving to tumor concept. Now, these become very difficult in terms of management because we don't know as yet whether they are as aggressive as conventional neuroendocrine tumors or not. Now, with the exception of all these precursor or what I call baby neuroendocrine tumors, we regard all PanNETs as malignant. And then comes the question, which is a big problem, pathologically, is there a reliably definable, recognizable adenoma, meaning I can tell you this adenoma, don't worry about it. Is there such a thing for neuroendocrine tumors? And let me tell you from the get-go, no, there isn't. And I'll come back to that by showing you the data for it. So the story of PanNET has gone through a lot of reiterations and goes to show you from where we started. In 1996, FIP vesicle neuroendocrine tumors that were less than 3 centimeters were all called macroadenoma. Perfect, benign, no problem. Of course, immediately data start to come with longer follow-up that they ain't no adenomas. They kill. They're especially 3 centimeters. Then WHO realized, okay, we have to do something. There's no adenoma. How can we define the more benevolent ones, benign behaving ones? If they are less than 2 centimeters, it's less than Ki67 is very low, no lymph node metastasis and no vascular invasion, then it's benign behavior. Now, this concept I always found to be very awkward, very, it's not good, if you will, because, of course, if the tumor is not metastatic, if it is showing it's very small, low grade, low stage, and if you operated on it, of course, it's going to have benign behavior. That's true also for breast cancers. Breast cancers that are 1 centimeter, 99% 10-year survival, right? But we interfered. So nobody now says, let's watch breast cancers that are smaller than 1 centimeter because they survive for 10 years. So this is a very controversial and problematic concept. So, of course, more data accumulated, more follow-up, and then we came down to saying, yes, these are malignant. They are T1 malignancy, small, but mostly curable. Now, one thing that got omitted from this statement, mostly curable if resected. So, unfortunately, the follow-up starting in 2010 in the US and later on Europe, let's watch these things if they are smaller than 2 centimeters. Now, let's tackle that data and the controversy on that topic. This is a beautiful paper from Carlos's group in MGH Mass General. They followed numerous patients and they found those incidentally discovered PanNETs resected. Of the 39, 2 that were smaller than 2 centimeter were metastatic in 7.7%. So you may say 7.7% is not much. Or you may say, wait a minute, 7.7 is a significant, especially considering the follow-up time and especially considering these are resected. And that's actually what this letter to the editor for the same paper is saying. Charles Walmer, I'm sure many of you know, has a very good sense of humor too. He titled this paper, Incidentally, It's Still Cancer. You know, because it was referring to the incidentalomas. Incidentally, it is still cancer. So what he's saying is, yes, they may be benevolent if you resect them, but in follow-up, many of them prove to be malignant. So these are still cancers and should be classified as cancers. And more data on these. If you look at lymph node positivity rate in resected PanNETs, about 10% of the doses that are smaller than 2 centimeters in our database is 10%, in some databases up to 15%. So this is a PanNET, smaller than 2 centimeters. For whatever reason, resection has been performed. About 1 in 10, 1 in 6 will have lymph node metastasis, even right there and then. So it's already proven its malignant nature. And we know that average size of resected PanNETs is 3.5 centimeters. So actually, we're not saying, you know, it's not like these tumors are usually 15, 20, and 2 is the very small version. I mean, actually, about 30% of them are smaller than 2 centimeters. So we're not dealing with a very small subset here. It's a significant issue. And one concern I have from surgery literature is this is what oncologists and us pathologists see. We see a liver biopsy. There's a metastatic neuroendocrine tumor, DOTA PET is done, or whatever mechanism. Oh, whoops, there's a pancreas tumor that is 1.5 centimeters. See, those patients don't come to surgery as much, but oncology literature and pathology literature experiences these things. And that's not captured in some of these papers that advocate watchful waiting. Also, there are some more, by the way, in the SADOT data, I don't think I may have deleted those. Oh yeah, sorry. That paper that led to all these things, the SADOT paper, their follow-up is 44 months. So they're concluding on the behavior based on less than 4 years, which of course, these tumors is very inadequate because most of the mortality comes after 5-6 years. And they also selected the patients as low stage to begin with, so they eliminated. So there's a very select group, short duration follow-up, that watchful waiting is based on really very incomplete data is the concern. Here are some things that are coming up in the last few years. Analysis of these databases, NCD database, National Cancer Database. This is one of the American College of Surgeons has this database. And every comprehensive cancer center needs to put their data into this database. And it uses mostly comprehensive cancer centers data, meaning not just primary institutions, smaller places, but really accomplished cancer centers data. So this is probably one of the more reliable databases, especially in the US. There's also a SEER database, which is not good at all. It collects data from everywhere, and it's very contaminated, very inaccurate. It gives some good ideas, but not as good as the NCDB. When you're reviewing your papers, if it says SEER database, you should sit back and say, there may be a lot of issues here. If it is NCDB, still, it's a database, it's inaccuracies, but more reliable. And this database shows us that the resected ones versus unresected ones, the survival difference is very striking, obviously, not surprisingly. But more important is when you look at the 5 years of the unresected ones, it's 60%. These are all less than 2 centimeters. So 5-year survival, unresected PanNET. If we look at this database, it's 60% survival, 40% dead. That's quite significant. By the way, I borrowed some of these slides from a colleague in Champalimaud, Anajao, who gave a very nice presentation together with me on this topic. And I asked him to borrow these slides because they're quite nicely illustrating the issue. Same also for when the size is broken down is 1 to 2 versus less than 1 centimeter. Again, 1 to 2, you have 5-year survival illustrated here, actually even lower than 60%. So this shows that they are really malignant. Similarly, between 1 and 2. So this is the group, less than 1, I think data shows you might be able to watch. And if this, by chance, a patient that's not going to grow her tumor or his tumor may be okay. Once it becomes more than 1, then a resection may be indicated. But what I see in this data, at least personally, if it is 1 to 2 centimeters, it really warrants resection. Again, of course, I'm a pathologist. It's easy for me to say. Whipple still has 2 to 10% mortality when we look at carefully. And we're saying it's less than 2, less than 1. But if we are honest, I was reviewing some papers from Europe, some data from Europe there. Oops, I did something. Bir şey yaptım ama burada. Kablodan olabilir. So in European, in Europe, their databases are showing 5 to 10% mortality of people. So I understand that resecting a tumor that is more slow growing is easy for pathologists to say, not easy for surgeons to do. But at the same time, if we're going to do watchful waiting from pathology perspective, I can tell you, we should do it by understanding that these are malignant and some of them are going to die. So it should be very selective and very carefully employed is the point. And this also shows a very similar result from the SEER database. This is the database I was referring to that as being unreliable. Surveillance, epidemiology, and results. Some states are having this database. All institutions send their data, but this shows even more striking and worrisome results. But like I said, I suspect some of these are PDACs and other cancers that were misdiagnosed. That happens in SEER much more often than NCDB. I mean, I wouldn't rely, because this is even worse. Look at this, is almost like 45% 5 years. But probably NCDB is much more realistic in this regard. So, so then I don't, if you ask me, is this a benign PanNET? My answer is there's no such thing, except for those little proliferations in syndromic patients like MEN, etc. Can pathology help? And this part is probably more for pathologists. Can pathology help in establishing which patients are more likely to progress? We have been tackling this question. This is one of the studies we've done with the collaboration, and Orhan was the first author here. In many endocrine organs, a capsulated, demarcated tumor is very good news, such that in thyroid, if a tumor is capsulated, we call it an adenoma. We call it benign. So, we know most endocrine organs, this holds true. So we analyzed this concept also on PanNETs, and we found that indeed those that are very demarcated and partially capsulated do much, much better than those that are highly infiltrative. Not a surprise. It's just that I don't know where we were all these years. We should have been doing it all this time, but we don't. We weren't. We will. Because the progression risk of highly infiltrative, by the way, these highly infiltrative ones, all morning I told you, demarcated, fleshy, etc., being non-ductals. Here we see the more aggressive examples. If I look at this, which I did actually, when I saw this case in the gross room, I said, this is probably going to be PDAC. It's so infiltrative, so spurious that I thought it was more likely to be PDAC. Now, this one I know is PanNET just by looking at the gross. So that is kind of the classification too. If it is resembling PDAC in radiology or gross, if it's not demarcated. So actually, I think our colleagues in gastroenterology and radiology might be able to help determine the behavior of these tumors more effectively in the future by paying attention to these parameters. When we looked at our database, those cases that were smaller than 2 centimeters, it was only one case out of 28 that was demarcated that had aggressive behavior. Our follow-up is about 4 years, so it's not extremely reliable, but it just shows at least the trends, because we see that the numbers go really high for cases that are more infiltrative. When you come to the most infiltrative cases that are less than 2 centimeters, half of the 4 of 8 patients had metastatic behavior, liver metastasis in the follow-up. So this is something, if you happen to catch it, these probably grow very fast, so we may not be able to catch them less than 2 centimeters, but some of them present that way. I think these really should be resected. Another thing is, again, if you have a tumor that's less than 2 centimeter, invasiveness, capsulation may be one parameter you can use. The other one is the Ki-67. Ki-67, we used to say, notoriously unreliable in the sense that it doesn't really correlate that perfectly with outcome. It doesn't stand the multivariate analysis. However, when you break it down a little bit differently, and we proposed this 2A and 2B, and now WHO, it looks like, is going to advocate that and put it in the classification. If it is, and this 10%, by the way, was being used by oncologists in metastatic liver cases and extensively. They actually use that 10% more than anything else. So if Ki-67 is less than 10%, we call it G2A. If it is 10 to 20%, 2B, and the metastatic rate is strikingly higher, again, not surprisingly, but when we start to use 10%, it sounds like Ki-67 is going to be a lot more predictive and useful in our daily life. And when we looked at our PanNETs that are less than 2 centimeters, 3 of the 6 cases with G2B, meaning more than 10, less than 20 Ki-67, had liver metastasis. Other things we are working on to hopefully help in predicting the PanNET behavior are the cytologic, morphologic features. This has become quite well established now. We propose to call metabolic cell or more oncocytic examples do a lot more aggressively. And we have seen cases with Bilge as well. When they're oncocytic, they're often metastatic. So when we see these, we notate so that they can be followed more closely. So going back to our main question that I wanted to tackle, is there a reliably definable, recognizable adenoma, neuroendocrine adenoma in the pancreas? The answer is not really. They're all malignant, but if they're really small, especially less than 1, fully capsulated, very low Ki, non-aggressive, the patient is 70, more comorbidities, etc., with close follow-up, I guess will be the approach. Again, I know this is easier for me to say, it's hard to follow, but at least if you ask me the biology of these tumors, this is what I will have to tell you. The reason I tackled this question is, patients find me, as you can imagine, and they ask me this question. So what should we do now? And I, of course, tell them, go and talk to your surgeons and clinicians, but they want to know from what and I honestly have to tell them, look, this is the data. These things are malignant. There are watchful waiting approaches, but it needs to be done very cautiously and carefully. And this summarizes of the things that I said. I know this is a controversial topic. I hope there will be some discussions on this, and this is all I wanted to present to you. Thank you very much for your attention.